Sure. Uh, well, thank you, Wen, and privileged to meet all of you here and to have this opportunity to share with you and to engage with you throughout the day. As Wen said, I direct a project which is part of the U.S. Foreign Assistance Program aimed at improving healthcare. Improvement has sort of come quite a long way today. We're no longer satisfied with demonstrations of improved care. We're now talking about care at scale. And I've prepared a flyer which you should all have, and I'll just refer to a couple of things in it as part of the introduction. The first thing I have is a map. At the dark colors are the dark blue colored countries are the countries where we currently have work, and the lighter blue are countries where we had work in the past. I'm also showing the work under this ASSIST project, but this is a project that is a follow-on to several predecessor projects. The Healthcare Improvement Project preceded it, and then the Quality Assurance Projects 1, 2, and 3. And I've noted the numbers of countries, so you can see that there's been an increase over time. The Healthcare Improvement Project, which recently ended, worked in a total of 39 countries, and today, in the second year of the ASSIST project, we've reached 28, and of course the numbers will increase over the life of the project. Part of the reason why I'm going through this is because in the conversation, should I describe one scale-up project or should I describe the work at scale? That was sort of the conversation, and I'm going to talk about the work at scale and then maybe get into some specifics as part of the conversation later on. Just to give you an idea of the scale, the current scale, that is where we are today, we are working with multiple partners. The partners include the governments that we are serving in the different countries, that with a large number of facilities in excess of 4,000, in excess of 900 communities, 2,500 teams, and sort of the people in the areas we're working with. So they're not necessarily the people we're serving, but the communities that we're serving amount to about 96 million people. The work that we do is basically we're addressing, given the nature of this work, it's addressing the global health priorities. I don't expect you to be able to read that, but you do have a flyer with that information on it, and the symbols underneath are the technical areas of work. So you can see there that we have work in the global health priorities, which are HIV, TB, malaria. There's maternal, neonatal, child health, community health, health workforce development, etc. And the different countries will have one or more of the technical areas, depending on what they have asked us to help them with. As I was preparing this, our regional director for Southeast Asia, who runs our program in India, sent me some materials, and I thought it was very interesting the way he framed his work in India. And the way he put it was this, that we're working with the Ministry of Health and Family Welfare. We're there in 263 facilities with a team in each facility, about 12 to 14,000 deliveries per month, and about 30% of the deliveries in 27 high-priority districts. He looked at this and he said, if, given the birth rate, he was looking at where the scale of the work that he's doing, he said, if just the 6 districts in which they are in India, and India has 1.2 billion people, so it's about a fifth of the population of the planet. So it would rank as like the 80th or 88th country in terms of the number of the sort of births that they're dealing with. So that's sort of about the scale of the work and about the technical areas of the work. How do we scale up? There's no one way for scaling up, and we've used a variety of methods. The mainstay ones that keep on sort of being used are, first of all, the collaborative improvement methodology that was developed by the Institute of Healthcare Improvement, and colleagues Marie and Joe here, and I'm sure many of you are already using this, and we continue to use collaborative improvement, bringing in multiple teams that work together. We heavily use extension agents. We have pretty much, in most of the work that we do, we deploy our staff or Ministry of Health staff or a combination of both who go to the facilities and help them, and they network between them and they carry information between. So there's a large chunk of our methodology that's dependent on the use of extension agents. There's the wave sequence methodology, which you may have heard of, and there's a publication, I think I've shared that, and if not, I'm happy to share that with you, and I'll talk about it in a minute, whereby we basically start somewhere and then we use the champions from the initial waves as spread agents to the remainder of the system. I'll get to that after this. But the majority of the scale-up efforts that we have are really some sort of hybrid of different things. So we don't go in and say, this is how we're going to do it. We sort of are much more adaptive in the approach, and we say, okay, what looks like a good combination of things that we should use in this particular setting for this particular spread at this time, and we sort of design it with those things in mind, knowing what exists out there and what types of things. But invariably, we're not sort of doing work that's single facility anymore. We are heavily using collaborative learning and improvement as part of that. And we're using a lot of extension agents and wave sequence. Let me talk just a couple of minutes about wave sequence. If this is the full geographic area we want to cover, this is just illustrative. Then that geographic area usually has some center, and the center has, and it has some sort of distribution. These could be districts, provinces, anything, each of which will probably have its own center. So we're sort of like, if this is a country, you can have different administrative regions with central cities, locations in them. The blue dots represent facilities where care is being delivered. And for the most part, we're dealing with nested systems that have some hierarchy, ministries of health usually, with referrals, etc. in between them. And those are the lines that we have on the diagram. If we look at them, then basically they cover populations. So those slices of the system are populations that receive services in those communities and those facilities. Wave sequence essentially is an approach that we would use if we can't reach all at once. So if we can reach all at once, there's no reason why we should slow ourselves down. But if we cannot, then what we do is we take a slice in each of the regions of interest, and we try to capture all the different care facilities or levels of care in that system so that we can design that. Earlier, somebody talked about a scalable model, so that we can design the scalable model. And once we've made the improvements there and we have a very good idea of what is scalable, then what we do is we look at the remainder of the system, what are the remainder of the slices in the system, and then we heavily rely on people who develop the initial demonstration in the light green colored slices to become the champions spreading to the remainder of the system. That's a quick, I hope I haven't gone much far over my 5 minutes, but I'm happy to engage in conversation and answer questions.
Wonderful. Thank you, Rashad.